yet.
That just happened when I
Bill
came
dealing
through.
with the boards.
It actually probably didn't delay any because of the congestion at the exit.
Yeah,
So that didn't take 15 minutes like it normally does. Well, the cops were there.
Those pens don't write very well.
I know, I think they want you to sign an ineligible ink so that it won't go away.
Will that work for that purpose?
I don't think it's indeligible, I don't know. Have you got one like this over there anywhere?
I don't see one.
They don't last very long.
Hey, I'll use that one. Make sure you get it back. Good morning and welcome everyone to the 933rd meeting of the North Carolina Board of Pharmacy. At this time, we'll officially open the meeting. We'll open the meeting as usual with the ethics statement, which says, in accordance with the State Government's Ethics Act, it's the duty of every board member to avoid both conflicts of interest and appearances of conflict. Does any board member have any known conflict of interest or appearance of conflict with respect to any matters coming before the board today?
No.
Let the record indicate they're all negative. If you do become aware of a conflict during the meeting, if you would identify that conflict and let us know, we will take action on that at that time. Before we start our meeting today, I'd like to ask everyone in the audience to introduce themselves to the board. Start over here with our esteemed leader, Josh.
Josh Kohler, Director of Investigations.
Ellen Vick, Associate Executive Director Report.
Christy Bush, Inspector Report.
Caitlin Brunson, North Carolina Mutual.
Tara Jones, I'm a pharmacy student at Campbell.
Patrick Brown, Mutual Drug. Matthew Harding, I'm also a pharmacy student.
Catherine Ray, I'm also a pharmacy student at Campbell.
Kristen Smith, Accounting Manager at Ford. Rhonda Jones, Director of Finance and Human Resources at Ford.
Denise Shelton, Executive Director for North Carolina Association of Pharmacists.
And I'm Ron Willard, Walmart, Market Director in Raleigh.
Thank you. Having done that, we'll also have a roster going around where you can sign in that you were here with us today. Glad to have you with us for sure. We have for your consideration, board, the minutes of the June 2017 meeting. Those have been provided to you. If there are no questions or recommendations for change, we'd now entertain a motion to approve those minutes.
So moved.
Second.
Let the record show we had a motion by Dr. Bowman, second. All those in favor say aye.
Aye.
Any opposed? Those minutes are approved. Mr. Campbell,
Thank you, Mr. President.
first agenda item.
The next item on the agenda, I'm going to yield to my esteemed colleague on the left here, Mr. Pena, who's going to give you the background on that.
Okay, thank you.
The next item is a petition to vacate a disciplinary order by Abdul Badir, a pharmacist, who has a 2001 consent order. Just as it is people's right to show up here and have a public hearing, it is people's right to decide they do not want to have a public hearing. He has waived the public hearing, and you'll see the waiver in there. And I said, I'll submit written materials, you submit whatever you want, and he has done that, and the board members can decide based on that. So you have written materials to consider. If everybody has read them, you're free to vote now. If not, I would suggest, Mr. President, that y'all take a little time to read them as the day goes on. If you need to discuss it, you can have a closed session. You just have to say on the record you're having a closed session to discuss it, and then vote when it's convenient.
Thank you, Mr. Pinion. I believe what I'll ask the board to do in regards to this is, at your leisure, to take a look at this information that we have presented. And I will call for a closed session to discuss this, either right before or right after lunch, depending on our progress through the meeting today.
And we do have one other closed session
Okay.
matter, so you can do both.
Okay. If that is okay with the board, is everybody okay with that? So having said, thank you, Clint, for that information, so we'll handle it thusly.
Next item, Mr. President, I wanted to update everyone on the continuing education program that the board sponsored. It's held on June 26th. Thanks to hard work from Steve Diedrich, Austin Companion over at Nancy Eshman School of Pharmacy, for Penny Shelton and the North Carolina Association of Pharmacists, Leslie Wilson, here of our staff, who handled the vast majority of the logistics of this. The reports I'm getting back are that it was an unqualified success. We had over 1,000 pharmacists who participated in that CE, either live or remotely. I've gotten, so far, we haven't gotten the formal evaluations back from Mr. Diedrich, but the feedback I've gotten was that folks found Joe Ranazizi to be an engaging and informative speaker. There were good questions asked. We did not, I think I was freaking out more than anything else about whether the IT system would support that many people who were logging in. We did not get any complaints about that. So I think you guys deserve a lot of credit for wanting to take some proactive steps to help pharmacists and others in the state as we're looking at controlled substances issues. Steve told me as of yesterday, I think they were up to close to 600 of the participants had actually claimed their credit. I expect that'll probably level off somewhat over the next few days and then spike again right before the 60-day deadline to get the evaluation in. Friday Center was terrific. I am having a call with Steve and with Austin on Thursday to discuss the potential, including the costs that would be involved for making that, we did record the program, to making the program available as an on-demand continuing education course going forward. So I will have a report to you guys once I've met with Steve and know what would be involved with doing that. But I know most of y'all participated.
Thank you. I would suggest that if you do make the online version accessible, that you assign a fee to that.
Okay.
Because who does it belong to?
It's ours, more or less. I mean,
Well, we don't want to assign a fee that we pay to us.
That
I
would
would
be
guess.
paid to us.
Yeah.
If we're gonna do it, what we'd say is, and I'll talk to Steve about this.
Okay.
Essentially, what we'd be looking to do is say, what fee would UNC need to charge to cover their cost of hosting the CE program and
Right.
providing the CE credit? I don't imagine it would be a large fee, but to your point, Mr. President, I think it's from my perspective, I think that's a good suggestion because we won't have any control about how many people do that, so we could wind up.
It could cost somebody some money. That's right.
Yeah.
I think that I'll take the liberty now, since we also about the next week, I think the STOP Act passed. Would you, two things. I think it's also a good time to reinforce the fact that the way that the CPE monitoring all works now, once you apply for credit to a CE such as that one, it automatically goes into your CPE monitor.
That's correct.
And so-
CPE accredited CE, which this was.
And that's all we have pretty much recognized now as ACPE.
NCAP, we recognize NCAP
Okay.
accredited and precepting for one of the North Carolina pharmacies.
So after this,
January 1st.
so after this year, when you renew your license, you're just going to indicate you do have the CE and that's it. And the
That's
CPE monitor is going to be there to substantiate that,
That's
that
correct.
type thing. And it makes it a lot simpler for pharmacists, I believe, and I think it's a good time to say that.
Yep.
And also to further move down that line as far as this program we had, would you highlight the STOP Act and also how you think the board can best address getting the information out to the pharmacists of what they do or do not have to do or need to do?
Yes, I would be happy to do that. In fact, if you will all jump to the legislative update tab and click on that. If you'll scroll down in the materials behind that tab to page, sorry,
Is it S?
page 20 of the material. There are 26 pages of materials behind the
Okay.
legislative update. If you'll scroll down to page 20.
So on our tab on the side, just Draft Guidance Act or
Yep,
STOP Act? Okay.
That's it.
Okay.
I have there, and I will, if you want, Mr. President, I will just sort of run through that.
Yeah, my goal was to let the public hear, maybe we're on the air,
Sure.
also the people here to know what how it directly impacts the practice of pharmacy on a daily basis.
So you're correct, Mr. President. The General Assembly has passed, and the governor has signed into law the Strengthened Opioid Misuse Prevention Act, also called the STOP Act. The STOP Act contains a broad array of provisions in it that are aimed at improving North Carolina's response to the opioid abuse and misuse crisis. It does make changes. Those changes that are most specific to pharmacy practice are changes with respect to naloxone distribution, prescribing of targeted controlled substances, and I want to come back to that. That's an important piece. Dispensing of targeted controlled substances, disposal of targeted controlled substances, and CSRS use. And you'll see in this draft FAQ, and by the way, members, this draft FAQ, my hope is that at the end of today's meeting, if you believe this covers what it needs to cover and does so appropriately, the plan is to get this posted and out there by the end of business today. Again, an emphasis is a state statute. It is not a board rule. So let me just sort of run through the big topics. There is language in the STOP Act concerning naloxone dispensing and distribution. However, the STOP Act does not change in any respect pharmacists' authority to dispense naloxone pursuant to individual prescriptions that the pharmacy may receive, or to dispense naloxone pursuant to the terms of the statewide standing order, which, I'm sorry. Pull that closer. You got it. Is that better? Can you? I guess I'll get.
Tell them there's plenty of seats in here.
Yeah, that's it. I'm sorry, but the statewide standing order in which several hundred pharmacies are already participating, and more information is available about that program on a website called naloxonesaves.org, which is a website maintained by the North Carolina Department of Health and Human Services. That website includes the statewide standing order, educational materials for prescribers, dispensers, and patients regarding the use of naloxone, as well as a Google Maps-based tool that shows by county every pharmacy that participates in the statewide standing order. So no change to that. There's been, of course, lots of discussion about continuing to make naloxone freely available to the extent possible. Pharmacists can and should continue to be a part of that. Nothing in the STOP Act changes it. What controlled substances, either dispensing or prescribing, are affected by the STOP Act? It's not all controlled substances. The Act defines a universe or a subset, I should say, of controlled substances, and they are called targeted controlled substances. And they fall into two categories. They are any Schedule II controlled substance that is an opioid or an opioid derivative. Okay, it does not include Schedule II amphetamine derivatives, barbiturate derivatives, or nabilone derivatives. It's purely opioids and opioid derivatives that are in Schedule II of the controlled substances. It also includes Schedule III controlled substances that are combination products that contain opioids or opioid derivatives. There are, of course, you all know, there are a number of categories of Schedule III controlled substances. There are certain steroids. Those are not included in this. So targeted controlled substances, it's all C2 opioids and opioid derivatives, all C3 combination products that contain an opioid or an opioid delivery. I imagine that's going to present a little bit of a challenge to some computer programmers to try to get that, but we'll see how that goes. So with respect to these targeted controlled substances, there are changes made both to the way those are to be prescribed and to the way that those are to be dispensed. With respect to the prescribing changes under the STOP Act, and this is not effective until January 1st, 2020, January 1st, 2020, all targeted controlled substances by state law will have to be prescribed electronically by January 1st, 2020, unless an exception applies. And there are a list of exceptions. Basically, one involves a dispensing physician or other who hands it straight to the ultimate user. Administration orders in inpatient facilities are not included. If there's a technical failure that makes it impossible for the prescriber to use their electronic prescribing tool, prescription is dispensed by a pharmacy located on federal property. I'm not sure why that's in there.
Do you know how we would monitor a technical failure on the
Well, I'm
pharmacy
coming to that.
Okay.
And veterinary prescriptions also will not be required to be prescribed electronic. So, yes, your question is exactly one. This is the one you guys raised a couple of months ago, and we communicated to the legislature, which is after January 1st, 2020, if a pharmacy gets a written or a call-in or a fax, legitimate prescription for a targeted controlled substance, how is the pharmacist to know whether one of the exceptions to the electronic prescribing requirement applies? And of course, the practical answer is that in the vast majority of cases, there's no way that a pharmacist could know that. Fortunately for pharmacists, the STOP Act provides a carve-out there and specifically says that a dispensing pharmacy that receives a non-electronic prescription for a targeted controlled substance, and all the indications are that it's valid and for a legitimate medical purpose, the pharmacy is not required to independently verify with the prescriber that an exception to the electronic prescribing requirement applies. So pharmacies, as they receive these prescriptions, will undertake the same due diligence that a pharmacist would undertake for any controlled substance prescription that the pharmacy receives today, but they are not required, if they get a written C2 prescription on January 2nd, 2020, to contact the prescriber and say, why did you send me a written prescription instead of an electronic prescription, and then have to document it was a technical failure or whatever. So same due diligence that's always applies, which certainly may beg the question, how is it that the electronic prescribing requirements are going to be enforced? I don't have any answer for you on that, and there's not one that's specified in the STOP Act.
Jay, is it reasonable to assume that this will drive providers to using electronic prescribing in general? Because why would they prescribe opioids only electronically and handwrite prescriptions?
Probably. I mean, I know there have been some CMS incentives for prescribers to switch over to electronic prescribing for all prescriptions, and so I think that's driven a fear of it. But yeah, I do think it's a fair observation that those who may be holding out, this might be a little additional nudge to go that way. And I don't know, my personal opinion is that probably at the end of the day is a good thing, including for pharmacies in terms of receiving those. But yeah, it's just one more incentive to do that. And I do think you're right, Andy, that if you're going to invest in an electronic prescribing tool, it doesn't strike me as making a whole lot of sense to say, well, I'll have an electronic prescribing tool for controlled substances, but not anything else.
Right.
Jay, the logic of January 1, 2020, is that simply to give prescribers time to get electronically set up?
That's my assumption, Mr. Haywood. I don't know that for a fact, but I can't imagine what else that would be there for. I think there was originally an earlier implementation date. I think that was negotiated quite a bit over the course of
I guess the number of physicians that don't have it would mandate 2 years. I don't know.
We'll see. Be a good time to be an electronic prescribing system salesperson.
Yeah, it would, wouldn't it?
That's right. The second prescribing change, and again, remember this is with respect to targeted controlled substances, not all controlled substances, are those that are prescribed initially for the treatment of acute pain or post-operative pain. These provisions are effective January 1st, 2018. On that date, on and after that date, a prescriber may not prescribe initially more than a 5-day supply of a targeted controlled substance on an initial consultation for acute pain. The STOP Act does define acute pain, and Gene, I know what your question's gonna be, I've got an answer to that one too. Or they have, whether it's a good one or not, reasonable minds may disagree. STOP Act defines.
So acute pain, not one that looks real good, is that what
Yeah,
you're saying?
It's not
Okay.
acute, it's not ugly pain, it's acute pain.
Okay.
Pain whether resulting from disease, accident, intentional trauma, or other cause that the practitioner expects to last for 3 months or less. The term does not include chronic pain or pain being treated as part of cancer care, hospice care, palliative care, or medication-assisted treatment for substance use disorder. Likewise, on this effective the same date, the prescriber may not prescribe more than an initial 7-day supply of a targeted controlled substance for post-surgical procedure, acute pain relief. And there's a definition there of a surgical procedure. I'm not going to read that one. It does, I think, reflect what you all would think surgical procedure is. So for initial consultation for acute pain, 5-day initial supply limitation, initial prescription for post-operative acute pain relief is limited to a 7-day supply. Now, the STOP Act does not limit a prescriber from issuing additional prescriptions after the 5 or the 7-day initial prescription if clinically appropriate. But then, sort of similar to the question, well, how is a pharmacy to know? And this was another issue you guys had identified when we wrote. So the question that, of course, will come up is, you're at a pharmacy and you receive a prescription, let's say, for a 2-week supply of a targeted controlled substance. And of course, it's exceedingly unlikely that that prescription will say why it's being prescribed. So what obligation does the pharmacy have to call the prescriber or otherwise get in touch with the prescriber and say, is this for an initial acute pain consultation or is this for post-operative pain? If so, I can only fill 5 or 7 days worth. The STOP Act, though, says that a pharmacist who receives a prescription for more than a 5 or 7 day supply of a targeted controlled substance is not required to verify that it's a prescription to treat something other than acute pain or post-operative acute pain relief. Now, I do want to emphasize, though, that doesn't mean that pharmacists don't have the duty that they always have, which is to assess any prescription for a controlled substance that's presented to try to determine if it's for a legitimate medical purpose and valid. But again, if you get a prescription for a 2-week supply of a targeted controlled substance, let's say, and there's no indication of what it's for, the pharmacist doesn't have a specific legal obligation to call the prescriber and say, tell me what this is for, or tell me that it's not for an initial acute pain or an initial post-operative pain. So that's where we are on those.
Jay, I think it's important to point out here that, we are seeing some prescribing where they're including, disease states and so forth
it's
on
great when they do.
prescriptions, even a list of allergies in some cases. And whatever we can do to work with our physician brethren to move everyone in that direction, not just for opioids, but for all prescribing, for us to have the information there of what they're treating and a list of, allergies that we can vet with what we have in our system. I think that's tremendously beneficial. It's kind of silly that we do it for one isolated set of things and then don't do it for everything else.
I think there's probably a generational aspect to some of that too, Andy, that younger physicians are probably a little more inclined based on training to include an indication. So I share with you, I think the more information a pharmacy has and can use to treat the patient is good. And like I say, I don't want to overstate the issue is that the fact that a pharmacy isn't required to sort of prove to me that this is not for, that's not intended to be to say, well, you don't ever have to work with your prescribers. I mean, you should continue to do that, but this doesn't oppose a new requirement of that.
Can you document with the patient information by talking to the patient?
I don't see any reason why you couldn't do that.
And this part of the STOP Act goes into effect January 1, 18.
That's correct. That's correct.
So we got 6 months to practice.
Yep. That's correct. There's one additional prescribing limitation, and this actually is already in effect. the Stop Act requires PAs and NPs to personally consult with a supervising physician before prescribing a targeted controlled substance for any patient being treated by a facility that primarily engages in pain management or that advertise their pain management, engaged in pain management services, or if the PA or the NP expects the duration of therapy of the targeted controlled substance to be more than 30 days. Now, just by further background, medical board rules already limit PAs and NPs to prescribing a 30-day supply of a Schedule 2 or 3 medication. For Schedule 3s, NP and PAs can both prescribe refills as allowed under federal law. But that's just sort of a reminder thing. Again, clearly pharmacists aren't going to be in a position to know whether a PA or NP has fulfilled that personal consultation requirement. That's going to be an issue, I assume, that will have to be monitored and handled between the supervising physician and any PA or NP that he or she supervises. And then if that sort of consultation is not going on, I presume that that would be an issue for the med board to deal with for the NP, or the nursing board as well for the NP or the PA. So again, the same advice applies. The same duties of due diligence that pharmacists have always had apply here, but there's no imposed duty to have documentation from the PA or NP prescriber under these circumstances that personal consultation has occurred. So those are the three significant changes with respect to the prescribing of targeted controlled substances. There is a disposal, well, it's not really, it's a little bit, maybe misstating that slightly. The Stop Act does provide, and this provision is effective already, that any hospice or palliative care provider who provides a targeted controlled substance to be administered to a patient for hospice, in-home hospice or palliative care is required to provide information to that patient or to the patient's family about how to properly dispose of controlled substances that may be left over. So it's just an information providing duty on the provider who prescribes. I'd have included it in this FAQ because it seems to me inevitable that pharmacies who are serving hospice and palliative care patients are going to be asked by providers and others, can you help us develop this information? Or may get calls from those patients or their family or their caregivers to say, hey, we got this information about disposal of unused controlled substances. Can you help us? Can you point us in the right direction with some of that? So I do mention that in the FAQ. I do provide a link in the FAQ to the means by which a pharmacy that wishes to set up a controlled substance take-back program, how they can do that if they choose to do that. Then with respect to the CSRS, the Controlled Substance Reporting System, there are a number of changes that have been made there. I do, in this FAQ, remind pharmacists and pharmacies that the Board of Pharmacy does not administer the CSRS. It is administered by the Drug Control Unit at the Department of Health and Human Services. So I have provided here contact information for Alex Aspen, who is the program manager at the Drug Control Unit. So I'm certainly providing information that's clear from the statute, but giving this information to pharmacists who may have specific questions about implementation or rulemaking and the like should reach out to the Drug Control Unit. All right, so what are the CSRS changes? Effective September 1st of this year, September 1st, 2017. And this is not for targeted controlled substances. This is for all controlled substances. The time of reporting requirement will change September 1st. Pharmacies will now be required to report the required information for any controlled substance that is dispensed no later than the close of the next business day after the prescription is delivered, and then the statute encourages daily or reports within 24 hours. This probably, well, it should not be a surprise to anyone. I think you guys will recall that the last tweak to the reporting requirement said it's within 3 business days, but said that pharmacies are encouraged to report within 1 business day. That was pretty well a flashing signal that in the short term, they were going to move to a daily reporting requirement, and the STOP Act does do that, and that will become effective September 1st, 2017. I have no idea whether and to what extent moving to a daily reporting requirement will require any change in computer systems or the like, or what drug control will or won't say about any sort of grace period about coming in compliance again. That is something that folks would need to talk to Alexander. I mean, you guys, Keith, does your system, is it set up, will it report every day now? If that, okay, so probably it's not a.
So it's automated.
Yeah, it's automated. I don't have to do anything.
Yeah, I figured that probably most systems were automatically doing it.
And I get an email every morning. It tells me what was reported.
Perfect, okay. So, well, that's good. Then maybe it's,
The question is, how long does it take that information to get put out for general distribution?
that's the.
Is it immediate turnaround?
That I
I
don't
doubt
know.
it.
I don't know how quickly that information comes
Yeah.
in and then appears in the database for someone who goes back. That'd be a great question to ask the folks over.
I mean, if they're gonna get you to do it every day, how long is it gonna take them to get it done?
Right, you're absolutely right. I mean, the idea is we want something that's more real time. Is it actually available in real time? I agree. Relatedly now, there is now a provision in the STOP Act that becomes effective, the statute becomes effective September 1st. However, DHHS is going to have to do a rulemaking on this, so it's probably going to be some months before it actually becomes effective. But the STOP Act now authorizes the Department of Health and Human Services to fine pharmacies who do not report information into the CSRS as required by law, and who don't do that within a reasonable, and don't start doing that within a reasonable period of time after being warned essentially by DHHS that the pharmacy is either not reporting the information or is reporting incomplete information. And there are a series of escalating fines that I think start at $500, move up from there, and are capped at $5,000 per year. So if a pharmacy, and I think there are a very small number, like maybe literally less than 5 pharmacies who I understand still aren't reporting, they could get fined. But I think the real issue on the table is, what does the missing or incomplete mean? And the STOP Act requires the commission to adopt rules for implementing this section that include factors to be considered in determining whether and what amount to assess a fine. So what the FAQ says, and I think we all need to be cognizant of, pharmacists need to be very focused on whatever these proposed rules, as do we, and see what it is that DHHS proposes to do. And I think this will be, DHHS doing a rulemaking on, well, what factors do we consider in deciding whether to fine someone and how much. DHH obviously, I'm speaking broadly, does not have the same level of expertise and understanding of what the day-to-day practice of pharmacy is that you all do and that those we regulate do. And so I think and expect that there should be a great deal of pharmacist input with DHHS about whatever their proposed rules are. And I'm hopeful that before DHHS would publish or propose any specific rules, that they would have some discussion sessions and reach out to stakeholders and others. And certainly, as I find out about any of that sort of thing, I will let you all know, and pharmacists in general. Penny, they could well reach out to you, or if not, you might want to reach out to them on that. So this is really a piece to keep an eye on with that, and certainly any pharmacy that's not reporting into the CSRS regularly really ought to change that, because there will be financial.
You proposed to publish this, is that right?
Yes, sir.
I have a suggestion,
Sure.
and let me just, for my own edification, ask you, the timeline I'm looking at is September 1st, 2017,
That's when the
every
statutory piece.
pharmacist must report within 24 hours.
That's correct.
Also, by 12/31 or March 15th, 2018, or when you renew your license, you must be signed up with the Controlled Substance Reporting System or verify that you don't work where they have controlled substances dispensed. January 1st, 2018, the prescribing rules go into effect. Is that correct?
Correct.
And then January 1st, 2020 is the electronic prescription required?
Right.
I think a great addition to this would be to put that timeline on it.
That's a great
Did
idea.
the board think?
Yeah.
I know pharmacists tend to look at whatever they see the easiest.
I think it's a great idea, and there's so many moving pieces on
Yeah.
this. I'd be.
Thank you,
happy
Ellen.
to make that.
Also, this is pretty important. Do we have the ability to actually, might be getting a little deep here, email each pharmacist with a link to this where they would be asked to read it?
Yep.
I think we ought to authorize whatever that might cost to get that
Oh,
done.
the cost is just in
Okay.
our time.
Did the board think that's a good idea or a bad idea?
Yeah, we always post but yeah, we can certainly email to pharmacists as well.
I think it'd be a good idea. I think that the board has just said they're happy to post this as presented in the draft and with the addition of the timeline. And also, since it is pretty significant, and everything, I guess, is significant, but this is a lot of ramifications here if you don't know what's going on, to email this out to each pharmacist that we have an email address for.
No doubt about it.
Is that
It'd be good
correct?
probably to highlight the dates to make sure.
With the timeline,
Put
the
emphasis on
timeline is pretty doggone important, I think.
I'm happy to do that. And I'm happy to continue going through these other things, or if you guys have heard enough of that, I'll stop, whatever.
When are you hoping to publish it and when do you want
Probably
feedback?
a little-
I'd like to, I've
Timeline
got to add
table.
the timeline piece of it, but, you know, I could either get this thing,
So they'll look more
that
like
the email out, I've worked with Kristen on that, because there's, you know, a little bit of managing our bandwidth on that. But depending on what time we stop today, I don't see any reason I couldn't get the timeline added, this and get it posted today.
Yeah, I think.
Are you gonna leave in here, you dear reader may be thinking,
I don't have to.
well,
I'll take that.
it's kinda funny.
I think it'd be a good opportunity to change gears and come back to the legislative stuff in a few minutes. But I would like to ask Mr. Slaughter with Mutual, since he represents the wholesaler here, have y'all considered any actions that the wholesaler might be taking in regards to this?
Not this time.
Okay. It won't affect what you do on a daily basis, really, as far as what you do. Okay. All right, well, I really appreciate taking the time to cover that in detail. And,
Happy to do it, and again, I'll get the timeline added, we'll move forward from there.
Right.
Again, a lot of moving pieces. And speaking of emails and the like, just to give you all, and this ties in, Mr. Mint, your question, just to update everyone on the e-profile stuff, I think you all saw, we have now sent out to all pharmacies a notice that they should act now. All pharmacists who don't already have an e-profile number, which should not be very many, need to go ahead and get one, and all technicians who don't have an e-profile number, which is many, need to act. And so we put out all the information on that, and it's reproduced here. Again, you guys have seen it already, but it's reproduced here behind your tab. And as you know, we have made the decision that for renewal of permits for 2018, we're not requiring pharmacies and BME facilities to get an e-profile number yet, because there's not yet a simple means by which those facilities can just log on to NABP and get it, as there is for pharmacists and technicians. And so our feeling is, let's have a simple process for that, and then so we're looking at that. I'm sure that will get implemented next year for renewal.
Can I ask a question about that? What's the benefit of a pharmacy having a e-profile number?
It means then that we have a number that our staff can go onto the NABP e-profile system, and it helps more for us for out-of-state pharmacies, but it'll help our in-state pharmacies that are licensed in other states. It is a collection point, and we can go in and put in an e-profile number. What we will be able to pull up here is any inspection reports for that pharmacy, any disciplinary reports for that pharmacy. It just ties us into that central clearinghouse for all of that information. Clearly, it has no application to any sort of CE thing, which is the tremendous benefit to individual pharmacists of having an e-profile number, is that all of their ACPE accredited continuing education, you have to have that, and that feeds into the e-profile system. But for facilities, it's so that we have a ready means to access in the NADP clearinghouse inspections, disciplinary actions from wherever they may have happened all over the country. Now, we get some of that now, and what is it, Cindy, quarterly or monthly? We get the disciplinary.
We get them daily, but I check.
Yeah, get daily disciplinary reports, but not daily inspection reports. So this would get us out of the business of having to sift through these piles of paper on these pharmacies and looking at that.
To follow up, thank you, Bill, and to plead totally ignorant on this, is this practice of e-profile numbers for pharmacists and pharmacies, is this nationwide?
Yeah, it's well, for pharmacies, not yet, although it's coming.
But it's not yet,
Not nationwide, but e-profile numbers for pharmacists.
but not pharmacies.
Absolutely, it's nationwide. Again, I got to expect the percentage of pharmacists around the country that have an e-profile number's got to be in the high 90s
Yeah.
because they have to have it now to get their ACPE. And PTCB certified technicians, they all have an e-profile number. Our immediate challenge here is getting all the technicians who aren't certified technicians to get an e-profile number. But we're working on that and moving folks along. And for the same reasons, I mean, for certified technicians, they need the e-profile number for their CE obligations, because recall that a certified technician for PTCB has a CE obligation, and they have to use the e-profile system as well. For non-certified technicians, what the e-profile number gets us, and also our colleagues in other states, is again a clearinghouse. If we discipline a pharmacy technician or the like, then that goes into the clearinghouse under their e-profile number, and if that technician moved to another state from North Carolina, that state could access that, and vice versa. If a new technician came to us who'd been working as a technician in another state, and we can go in and easily obtain that sort of background information.
So every technician that is licensed by the board, and that should be every technician that's been there more than so many weeks,
Yeah.
will have to have an e-profile number to be relicensed for next year, is that right?
That's correct. That's correct.
And that's quite a few of them, and probably most of them don't have one, is that right?
Yeah, well, I think, Deb and I think our numbers are that somewhere around a third of technicians are PTCB certified, so they already have one. They may not remember it, but there's a way to go get that easily. And I shouldn't say that, probably most of them do remember because they have to use it for their CE programs. For the other 2/3 of our technicians, which is a large number, probably 11 or 12,000, they're going to have to get an e-profile number between now and February 28th, or between now and whenever their employer expects them to renew.
Is that online transaction, is it conclusive? When you finish the online transaction, do you get it then?
Oh, yeah.
You don't have to wait? You think the system might be overrun by
No,
that?
we had
Okay.
lengthy discussions with
Okay.
NAVP about that, and we are assured that the bandwidth is more than sufficient to support that. And with respect, Gene, to the pharmacies, it's not a bandwidth issue either for that. It's there's that easy interface that pharmacists and technicians have. That's not there yet. Now, we had explored some ways of assigning or transmitting our database up and having numbers assigned, but ultimately our feeling was that was going to create more headaches than it was going to solve. Better to wait until there's a simple online immediate e-profile acquisition ability for pharmacies and DMEs and go forward with it at that point. But that, when we get that up, that will be an enormous help to us on our or out-of-state permit applications. So.
That's for the states to require them to do that though, right?
Well, but they're going to have it for us.
Okay, so have to
Get
have.
licensed
yeah,
with us.
Okay, okay.
Yeah.
Jay, at the risk of having you repeat yourself,
You know I do that?
yeah. On the Stop Act piece with CSRS, for the few pharmacists out there that are not dispensing controlled substances, what's going to be the vetting process for getting that exemption?
Right. So what will happen is that at renewal this year, pharmacists will be required to attest, just like they attest for, will be attesting now for whether you got on CE. Either I have registered for access to the CSRS, or they will attest, I do not practice in a place where controlled substances are prescribed in North Carolina or to North Carolina residents. Now, how are we gonna police that? That's the $64,000 question. I mean, and we'll have to talk about that down the road, whether we're gonna do some sort of
So folks can,
audit on that or not. I hope not. That's,
so folks can wait till November that are in that position, okay,
yeah.
to attest.
Jay, the policing of that will be determined by staff, or will we have input with staff?
If we decide that we need to have some sort of program on all that, then we'll come up with a proposal that we will present to you all. And just like we did with the, back when we reset the inspection intervals and all of that, it'll be our responsibility to come up with a proposal that we bring to you and say, this is what we'd like to do. I will tell you, I'm not enthusiastic about the notion of going out there and doing some sort of audit on this. I think it ought to be the kind of thing, let's give at least a couple of years for, you know, my belief is that an expectation is that pharmacists are going to, we know that pharmacists stepped up to the plate really well in the past few years, especially after we created that online application process. The numbers went very, very well, and I think it's still the case. It's a higher percentage of pharmacists who have activated CSRS registration than any other group of healthcare providers who could get access. So I think pharmacists have stepped up without this sort of STOP Act requirement pretty well. I think this requirement obviously will push a few more to get that done, but I think we got some hard thinking to do about whether and to what extent it makes sense to spend a lot of limited resources going out and doing some sort of audit on the CSRS. I think we're probably going to be better off to continue to do what we're doing, which is provide positive encouragement. I mean, we're going to have to say, yes, you're required to do this, but that position statement that you guys helped develop and approve a couple of years ago about what the board's expectations are, in my opinion, that probably did more for encouraging folks to get access to and use the CSRS than anything else we could have done. So we'll do some thinking on that. But no, I'm not champing at the bit to do any sort of audit process on that, and would not implement something like that without presenting it to you all for your input and guidance on that. I'll try to wrap that. When we sent this information out about the e-profile number, we did include as well the information saying if you don't have a CSRS registration, go ahead and get one. And I know some folks are doing that because we got some calls about it. So, but it's certainly the case that there are a lot of different number acquisition requirements that are being thrown at pharmacists here in a very short period of time. So.
And thank you for verbalizing those. And I'm not tired of listening to you talk, but would the board approve us to go ahead and have the financials now?
Sure.
So we can have a break from you?
Or if y'all want
And you
to
can have a
take
break. No, I think we do. Is that okay with you, Ron? Crystal?
Yeah, that's fine.
We'll be done with y'all and you can go back and do something else. Try to break the meeting up a little bit. I hate for you to be monotonous.
I am that. I appreciate your.
Are you prepared? Are you ready to go now? Okay, I knew you were.
So underneath your financial tab, the first report is the memo to Mr. Campbell with a recap of the board's financial activity highlights for the month of June. The second report is the board's balance sheet as of June 30th, 2017. And on line 14, total cash and receivables are at $8.92 million, and line 30, total assets are at $10.99 million. And then under your liabilities and fund balance section, line 46, our excess revenues over expenditures for the current fiscal year is $1.3 million, and total fund balance, line 47, is $10.99 million. Moving on to the next report, we have a comparison of budget and actual revenues, expenditures, and changes in fund balance for the 9 months ending June 30th. And on line 26, we have total revenue of $4.21 million compared to the projected revenue of $4.19 million. And note that this is a favorable variance of $15,000 above our year-to-date target. And the revenue line items with the largest variances are the following. And on line 7, pharmacy permits is over budget by 22% or $34,000. And this is due to a $26,000 payment from Walgreens to change the name of 53 of their locations from Walgreens of NC to Walgreens Company. And on line 22, interest income is over budget by $19,700. And this is an increase of 53% compared to where we were last year. And when looking at each interest account individually, I determined that this variance is largely due to a 135% increase in our First Citizens Investments interest earned, which is a year-over-year difference of about $12,500. On the second page of this report, line 75 shows that we have incurred about $2.91 million in expenditures, which is $63,000 or 2.1% less than the projected year-to-date budget of $3.1 million. Most expenses are reasonably within the targeted projections except for the following. On line 49, association dues, which are over budget by $11,250 due to a $10,000 assessment as well as an increase in monthly dues. And also bank fees, line 64, is over budget by 14% or $17,500. And after digging into the numbers a little further, it appears the main driver of this variance is an 88% increase in the First Citizens Investment Management fees. These fees are $17,000 higher this year compared to last. But as I mentioned before, the fees are more than offset by the 135% increase in interest income.
So you all recall that, I mean, Robert, y'all probably changed our investment mix a little bit.
And then in regards to our credit card and merchant fees, they're actually trending slightly lower than last year by about 1%. The next large variance we have are both consulting, line 67, and legal fees, line 69. Together, they're about $32,000 under budget, and this is due to the timing of invoicing versus budgeting. And then the last large variance is on line 74, vehicles, and this is due to the purchase of one more vehicle than we had originally budgeted for. Can I answer any questions?
Association dues or condominium association, that's the building?
That's correct.
Thank you.
Thank you. I'm sorry to differ from the
Just
agenda,
so
but
everybody- and I mentioned it last month, but we, Crystal and Rhonda and the directors are doing terrific work organizing a proposed budget for fiscal year 2017-18. We are meeting tomorrow to discuss that more before I get out of town, and then for Robert and for Andy, we certainly are still on track to have a complete proposed budget for you all in early to mid-August, and are targeted, as you know, for late August to have our meeting to go over that proposed budget and make some decisions for final proposal and then present at the September board meeting for approval.
if this is inappropriate, you can just tell me to stop whenever you get there, but is the potential Walgreens Rite Aid consolidation been considered as far as the ramifications in North Carolina?
Well, I don't know the details on that, because as you know now, it's a totally different.
And I think this one now will probably move on
Yeah,
through.
probably is. I don't know, Gene.
'Cause it could be an impactful thing.
There was, I would say the Walgreens folks were very proactively communicating, especially with Wendy, about if the original plan, if it went through, what the timing would be, and prepared to do all the change of ownership change. But I don't, as I sit here today, Gene, have a good sense. Surely there are going to be, as I understood it, even with the different deal, the stores that Walgreens will be acquiring are located principally in the northeast, mid-Atlantic, and southeast. So surely we're gonna be affected substantially, but I don't know,
I think every North Carolina store will be affected, is what I hear, yeah.
probably.
Something to think about.
Yeah.
Thank you for the report, it's very clear, very concise, thank you very much.
Thank you.
We're gonna recess until 10:15. Back at 10:15, thank you.
Okay.
So invite you all to have lunch with us at some point in time. Mr. Campbell?
Thank you, Mr. President. I was just going to ask Mr. Pinion if there's anything to report on the decennial rule review there.
The decennial rule review process, you remember, is
Supposed to do
the
that.
process every 10 years by which we basically decide whether rules are necessary, it should stay in the rules, or unnecessary, it should come out. Y'all proposed a set of categories, and after comment, adopted a set of categories. The Rule Review Commission was not set to review that, or is currently set to review that in June of 2018, but there is a process for accelerating that, which seems like a good thing to do since we're already done with it. So I have submitted a request to the RRC to move that review up to September. And we'll decide at its meeting in August whether to move the rule review up to September. So, all that is to say, hopefully we will be done sooner.
To when they're out of
Oh, you had a
town.
common online database? I think that may still be a different issue. I think if you're all sharing in a common online database.
Well, let's say you go to a region where that particular pharmacy doesn't have locations.
Yeah, right.
And so, you
Right.
know,
And you have one on file.
right, it just,
At Smith Pharmacy
Right.
and you, like, yeah.
somebody needs their Lyrica, somebody needs, you know, what, it's not an opioid, you know, and so, I don't know, I just,
You're preaching to the converted.
I think we can do better than this.
I'm happy to communicate back to the DEA or ask, but, I will tell you, my experience is their answer is gonna be, the question is asked,
You got
provide
an
an answer.
That's all I got to say
It's
about
not up for negotiation at this point, so, but I'm happy to provide, what I will say, and one of the reasons, and I'm not trying to be snarky about this, no, not to you, I mean, what I'm about to say, I'm always snarky, but one of the reasons I want to produce the email is that I do think that if pharmacists want to ask questions of the DEA, they ought to know to whom they can direct those questions. And I intend to provide them with that information. So,
But what was your comment about a common online database?
oh, that goes back, I mean, you all know, if you got pharmacy share a real-time comment, you know, there's always the limit, you can only transfer control once, unless they all share.
Okay.
Then you can move it as many
But you do have to
times, 'cause it's really
transfer,
not
yeah,
a
okay.
transfer, it's just moving around within the database.
It is a transfer.
Yeah, but I mean, you're right, but
Yeah.
it's functionally, it sort of goes to Robert's point, they
Yeah.
they don't have a problem with that because they view
It's
it
there.
as contained
Yeah.
within this database, so it eliminates the opportunity for, or lessens, I guess, the opportunity for manipulation, so. But there we are, people are gonna be delighted, to learn this, but,
And which people are you referring to are going to be delighted?
I'm, obviously, I'm speaking sarcastically, but.
Yeah.
Well, it's probably very few written prescriptions now, isn't it?
There's
Majority of them are
still,
electronic.
there's still a fair,
There's some,
still a
I'm
fair
sure.
number of them, but.
I don't know, but that's a lot of written prescriptions.
Oh, is it?
Yeah.
But it does go to, I mean, come 2020,
Yeah,
you're gonna have to do it here anyway, so maybe this is a problem that diminishes over time.
Yeah.
But it's still, for now, it's a real issue.
What do things changed? Like when they first started doing e-prescriptions, I bet half of them we got were really not done correctly.
Right.
But now they've gotten a lot better at selecting that type of thing. It's just, it'll move that way.
I agree. So are y'all okay with me just posting this? I mean,
Yeah.
it is what it
You
is.
can read them now,
Use
can't
the, use
So
the-
you could read some of them.
I'd rather read.
I
one.
will say, as an inevitable
I'd rather read one.
editorial comment, I think this all came about, I counsel people, it is important to know what your obligations are, but it's also important to think hard about how badly you want a specific question answered, because sometimes you ask them, and
That was exactly what I was thinking, and you verbalized it perfectly.
I think there's more than a little bit of that at play in all this. So anyway, they've asked the question, by golly. there
Is
it
Lyrica controlled?
Yes, it's a Schedule 5.
yeah.
I'm happy to move in, I can give it, this would not take us long at all, Mr. Minton, I can do it very brief on the other statutory stuff.
Oh, yeah, I just thought you might want to break earlier.
No, I don't
Yeah.
know what's
Yeah.
great. The other statutory things, the bills that were falling there toward the end, S8, military personnel occupational licensing boards, SH came a gut and replace, so those provisions did not get passed. So I expect some version of this will probably come up again, but for now, that bill is done. S104, you already knew that has passed. It's been presented to the governor for signature. I checked this morning, at least the database doesn't indicate it, but I've got no reason to think this isn't gonna get signed into law. And, so the next steps, that board staff have to do and come back and report to you all is, we're gonna develop a plan for, identifying potential vendors and putting out an RFP to do these, electronic background checks, and we're gonna need to work with ThoughtSpan, who's overhauling our IT system, make sure they integrate. I have a call with the ThoughtSpan folks on Thursday to begin discussing that, but the next stop point is once we know what technical, requirements we're gonna need, we'll be put together an RFP.
So, but you were doing a background check.
We do a sweep every night through the
So
agency, but it's after people apply or license on it. Before, people have to report. when
But you were doing a background check for potential licensees also, were you
Not
not?
all of them.
But some of them you were,
So-
right?
Oh, yeah. We used
So-
to self-report, and then we back up, and
Right.
then we did the AOC sweep on everybody.
So who were you using for the ones that you did it on?
We were doing, we did all.
Did
that through
ourself,
our
right?
Our
Okay.
AOC thing, so we're gonna need to look at, find somebody else. But again, there's, the real estate commission has a vendor that does this for them. So the first piece of information we need is what does ThoughtSpan tell us we need to make sure that any potential vendor has in terms of capability. So it'd be a little while to integrate this in, but, we need to do this right, with the integration. So we'll be working on that. Stop Act, obviously we already passed. S196, veterinary practice omnibus. Recall that requires the vet division at AG to do a study of veterinary compounding and report its findings and recommendations to JLABO in March. I reached out to Dr. Doug Meckes. I don't know if any of y'all have ever met him. He's the state veterinarian, essentially. He runs that division. Nice guy. And Dr. Meckes, I let Dr. Meckes know that the National Association of Boards of Pharmacy is having a veterinary compounding task force that is meeting in August, and I expect that some people in this room are going to be on that task force. And
Well, they better make the nominations quick then.
I think they're coming this week. I mentioned it to Dr. Meckes, would he like to participate as well? And so he's going to be invited to come. So I have some hope that maybe the NABP task force will come, will do most of the lifting on this one, and I'll keep you all posted on this. But Dr. Meckes was delighted that we reached out to him. He was perplexed by the bill as well.
Is that all the information we have, is that they want a study?
That's all it says. It's ready to study veterinary pharmaceutical compounding and report findings and recommendations. That's all it says. So, Dr. Max is scratching his head a little bit on that too. H701, that was the sort of the omnibus licensing board bill, did not come out of Senate rules prior to adjournment. It certainly could come back up in the short session because it passed the House, so we'll keep an eye on that. S407, that was that employee misclassification reform. It passed the House, but it passed in a different version, but the Senate and the House did not reconcile that before they late, so they could also take this up.
Jay, will these bills all wait to the short session, or will they come up like in September?
Oh, it's a fair question. I don't know, Mr. Haywood. I suppose it's possible some of them could, but I don't have any particular insight on that. But they could. And that's the legislative update. And then we'll say, like Mr. Haywood mentioned, they're adjourned, but they have potentially scheduled special sessions in August, September, and November, I think.
Oh, yeah, they'll be back 3 times.
Yeah. That's it.
Jay, which one of those bills address the per diem?
701.
701.
701. Anything else on that?
Investigative
Robert, I mean,
statistics.
Jay, just FYI, August 18, it's got nothing to do with y'all, but Robert will be addressing the Randolph County education piece on opioids. And since he's a board member, I just thought y'all ought to be aware of that.
It's cool.
Robert, if you'll send us, will you send us the specifics on that?
Sure.
We'd like to send some of the troops over for support there.
Yeah.
Happy to do that.
I'm gonna be there to support you, Robert.
Good, appreciate it. Behind me all the way. I'll bring you up there with me.
Use him for a shield if you're gonna be behind him.
That's right.
Okay. Good
Oh,
idea.
that question's so simple, I'm gonna refer it to Mr. Stanley.
Oh, sorry about that.
Okay, so on the investigation section stats, cases as of the 10th of this month, we were up to 108. Not much change in the order of what we've been getting. Procedural legals still in front, inspection follow-ups, and then diversions, errors, incident reports, and substance abuse. So needless to say, all of my folks are busy and have plenty to do. Surrenders as of 10th of this month, we're hanging at 14, 6 techs, 5 pharmacists, and 3 pharmacies. And I know we have some stuff for closed session.
Josh,
Yes, sir.
the substance abuse cases, that few they are, but are they primarily pharmacists or are they primarily technicians?
Pharmacists.
Pharmacists use them, technicians sell them, right?
That's generally the trend, you know, the technical ones need the
So
money. They need the money more than pharmacists, you know, since they consume it more.
Thank you, Josh.
All righty.
Appreciate it. I know we have a closed session coming up. Mr. Campbell, did you want to speak on the other things on the
Yeah,
agenda?
real quick, just a reminder, District 3 is coming up. I think we're all set on that, and Cindy's been sending out reminders about registration. If you have any questions or need any arrangements made, check in with her or go for board retreat. I'm getting good topics for the retreat. Continue to send your cards and letters, and I'll collect those. And
When would you anticipate having a preliminary agenda on that?
Certainly, I don't see any reason we couldn't have it by the end of August.
Okay, make sure the board have a chance to look at it.
Absolutely.
Okay.
And then Multion's coming up in October, and Cindy has the registration for that.
That should go out.
So just be able to look out for Multion.
We don't have an agenda for that either, do we?
I'd
It's
Cindy on that.
ready, it's just being reviewed, but it'll go out with the registration.
Committees, budget finance, we already talked about. Telepharmacy committee, Stan and Bill, or that committee, looks like we've about locked down a visit to North Dakota in early September to go do site visits and telepharmacy stuff, so there'll be an update after that has occurred. And to all board members, the current issue, the NABP Innovations magazine has an article about telepharmacy practices that I commend. Opioid Crisis Response Committee, that is Stan and Keith, and we're gonna huddle up after this meeting. We're looking at some programming possibilities, and I have an update on the homework assignments on that, so we'll probably have something. I'm probably gonna have something to talk about with that at the retreat.
I remember reading an article here the last week or two that talking about opioid, the prevalence of use, that type of thing in the United States has actually gone down some. Other countries has gone up. Have you read anything like that?
I haven't seen that article.
I saw it.
Which I don't know, relatively speaking, how much gone down from what to what, that type of thing, and that was interesting.
Jay, what's the head count on people going to District 3? me, okay.
That's, there are a couple of consent agenda items. The only thing I would call to your specific attention is the proposed consent order for Janice Dykert. That comes from a pre-hearing conference that was held yesterday with Mr. Mixon. And again, Mr. Mixon, thank you yesterday for your time and attention on that case. So that's one that was a late add if you had not reviewed those, but that's the only change to the consent agenda.
I want to look at this just a second.
Sure.
I should have looked at it earlier. You're talking about, which one you talking about? You've got a conference that was held on June the 18th, 2017, and that is determined that a pharmacy staff falsely reported to a patient the prescription was filled correctly without investigating. Is that right? Does that happen often?
I would defer, I was not at that pre-hearing conference.
Yes, that is correct. There are other elements at play in that. This is only as to the permit.
I'm talking about the permit right now. And so we would propose a letter of warning be issued to permit. Is that a discipline?
No.
Okay. Just a question for my own information, I guess. The board, of course, I guess that Dr. Bowman will be recused from the Walgreens action. And if the board want to approve the consent agenda at this time with a motion?
Motion.
Second.
All those in favor say aye.
Aye.
Any opposed, no. I guess the record will show that Mr. Bowman was not involved in that.
And then we could, although if we could take a short break, it would be great. We do have two items for a closed session. One, a potential summary suspension issue, and second, any debate and discussion on the Bookyard matter.
I would propose that we go ahead and go into the closed session to handle those two, and we'll do the summary suspension first. Then we'll just continue the closed session in the conference room back there. It'll give us the time to sit down and read through the other, and then we'll act on that. So based on that, we need a motion that we actually move into closed session.
Motion for closed session?
Second. All those in favor say aye.
Aye.
So we're going to be in closed session. Hopefully we'll have an early lunch today. Thank you all for attending. Appreciate that.
Gene, the question you just asked, Clint answered, there were other circumstances there, and I think in light of the total